Hi guys, it's Dr. Gillard here. It is Tuesday, week 8, spring of 2021. Let's talk about cystic fibrosis. A little bit in general, but we're going to be more, this is GIGU class, so we're more concerned about how it affects the pancreas. Now this is maybe a touch longer than normal. Monday's lecture was a touch shorter than normal, so this is going to kind of make up the difference here. Cystic fibrosis is definitely a life-shortening disease. The average lifespan is about 40 years these days. It used to be maybe a decade or two ago, 2 decades, 3 decades ago, maybe 30 years. We've come a long way with regard to treatment for this, but it is still a life-shortening disease. It's also called mucoviscoidosis, and the reason it's called that is because it kills by mucus. Specifically, the mucus that's associated with this disease is incredibly thick. It's like super glue almost. Super, super thick, and it causes all kinds of trouble. This is the most lethal genetic disorder in Caucasians, period, end of sentence. For example, about 95% of the time the child that's affected by this is Caucasian. It's much rarer in African Americans and people of Asian descent. It can affect many organ systems. In CVPP, we may talk about this a little bit more with its pathogenesis on the lungs, how it affects the lungs. But it does affect sweat glands, reproductive organs, lungs, intestines, pancreas. But almost all the deaths associated with this disease is secondary to problems with the lungs. And basically, in a nutshell, the mucus is so thick and tenacious that it sparks pneumonia after pneumonia after pneumonia, and the lungs become destroyed, and the patient literally suffocates, becomes hypoxic with the passage of time. May also affect the pancreas, intestines, as we said, also leading to significant morbidity. Mainly, it causes exocrine pancreatic insufficiency, EPI, also known as pancreatic exocrine insufficiency. And that can lead to malnutrition and all sorts of trouble. We'll look at that in a bit. It's typically diagnosed by the age of 5, and it's usually discovered by mom noticing that when she kisses her child, the child is really unusually salty. And that's a sign, and that usually the mom is the one who, or the dad, or one of the parents kisses the child and notices the child is really salty. It is an autosomal recessive disorder, so it takes both genes to be mutated in order to get this. You can be silent carriers of the gene, though. The incidence is rare, quite rare, in fact. It's about the same prevalence as Marfan syndrome. 0.01% of the population will have this. About 30,000 Americans are living with this right now. What's the cause of it? So the etiology is still evolving, not completely understood, but there's one thing that all types of cystic fibrosis have in common. There's a mutation in the cystic fibrosis transmembrane conductance regulator gene, and we're just going to call it the CFTR gene like everybody else does. So it's a mutated CFTR gene. Where does that gene live? It lives on chromosome 7. What does this gene do? Genes, of course, through the central dogma, make protein. And so it makes a protein channel, specifically the CFTR channel, which is a chloride anion channel. So chloride can move in and out of this channel. So here's an example of, in a cell membrane, we have a CFTR channel right here, and chloride is moving out into the interstitium here, whether it be a duct or into the duct or maybe the crypt of a gland or something, usually to meet mucin. Mucin is we know what mucus is, but what is mucus? Mucus is made up of mucin plus water. and that makes it more manageable. Mucin is incredibly, incredibly sticky, as we will see. There's 5 classes of mutations, and we're not going to go down into the weeds and all this, but just know the class 1, 2, and 3 are bad ones. If you have one of those mutations, you're in trouble. These cause severe defects, and these are the ones that are more lethal. And there's 2,000 different mutations and combinations that have been discovered, and we're certainly not going into that. But the classic board one, the one that everybody knows, I learned it as the delta F508 mutation. It's also called more correctly called a class 2 F508 del mutation for deletion mutation. And I used to go into a big genetic thing about that, but I took all those slides out, or this would really be long if I went down that rabbit hole. But in a nutshell, the mutation prevents the glycosylation, or the adding of a sugar to the CFTR protein. If you can't glycosylate the sugar, then the rough endoplasmic reticulum thinks that the protein is mutated, and it destroys it. So the deletion causes a misfolded protein, which is tagged by the quality control unit, basically the rough endoplasmic reticulum, and so it destroys them so they can't be put in the cell membrane, which is a shame because oftentimes they do still work. They're just a little bit different looking, but nevertheless they're destroyed in the rough endoplasmic reticulum. What are these things? We already said they're CFTR channels. They're chloride anion channels. They're found in epithelial cells. Specifically, they're found in the cell membrane that faces a duct or a crypt, a tube of some kind. That's, of course, the apical surface. Remember, the basolateral surface of the cell is the bottom of the cell that faces the interstitium, and the interstitium has the capillaries in it. Found mainly in glands, crypts, and ducts, the tubules of those things, and found in the respiratory tract, GI tract, pancreas, reproductive tracts, the exocrine sweat glands of the skin. Little different physiology with regard to these channels in the GI and in the sweat glands. And even there's a difference between the sweat glands and the GI system. What is their job? Well, the job most of the time is to pump chloride anion. We know what that is. That's a Cl with a negative. It's a negatively charged molecule. To pump chloride anion out of the cytosol of the epithelial cell and into a lumen of a gland or tubule or whatever, where it can attract sodium and water. And then together, the sodium and water and chloride, the salt and water, can surround mucin and thin it out and make it more manageable. Mucin, of course, is made by mucus glands or mucose glands. In the stomach, mucose glands, mucus glands everywhere else, and then goblet cells in the intestinal tract also make mucin. And there's in the bronchioles, there's epithelium that makes it too. So mucin is ubiquitous. It's everywhere. Super, super sticky. Again, it needs to be watered down with salt and water to make it function correctly. Okay, sodium and then water follow chloride and dilute it, thin it out. Yep, we said that already. We'll look at that more specifically in a second. So what about a defective CFTR channel? What does that do? If the CFTR channel is broken, then there's no way to dilute the mucus, and you're stuck with very, very thick mucin. That should be mucin right there in slide 13. This leads to a tenaciously thick mucin. I mean, it's really just pure mucin almost. There may be a little water in it, but and that clogs up the ducts and crypts and tubules, and it leads to all sorts of trouble. Like in the respiratory system, the tracheobronchial tree depends on the mucociliary escalator system to move gunk out of your lungs that you've breathed in all day, smoke and pollution and who knows what else. That needs to be taken out of the tracheobronchial tree, and there's a mucus escalator system, if you will, that uses mucus to trap particles, and we'll look at that in CVP a little bit more. So it's important there. It's also important in the pancreatic ductal system, as we will see, not only to thin out the mucin, but to make sure the pancreatic juice is basic. And we'll look at that function. And yeah, if it's not in the pancreas, if you can't thin out the mucus, you can get a very thick and sticky type of mucin that makes fecal material, or makes it very difficult for fecal material to move through the intestine. Here's just a run-of-the-mill idea how this works, and it's different, and this is just kind of a cartoon of it. But basically, we have a cell here, and then we have a tubule here, and we've had a goblet cell secreted this green glob of mucin, and it's way too thick and sticky. So chloride ion will diffuse through the CFTR channel, and it'll stick to the mucin. Chloride will attract its buddy sodium, salt, right? Sodium chloride. And then those two will attract water. Sodium really attracts the water, but so you get this kind of attack of the mucin by chloride, sodium, and water, and it thins out the mucus, or the mucin, and makes it a more manageable, normal type of mucus. That's the story. So you can imagine if this is broken and you can't get chloride, because sodium follows chloride into the lumen here, and then water follows sodium. So no chloride, no sodium, no water, super stick raw mucin. See how that works? When we talk about the pancreas, there's another player called the bicarbonate chloride exchanger that is also very important. This is relatively new research. So I'm not sure if this will be on chiropractic boards or not, but you never know. And yeah, these are also involved, and we'll see how that works in a bit. But it turns out that bicarbonate is also needed to make the mucin more manageable, more watery, more hydrated. And we'll see how that mechanism works. Plus, bicarbonate is very basic, right? It's a fairly basic molecule. And that's secreted inside the pancreas, inside the pancreatic juice. And it's what makes it basic and not acidic. Okay, what about now? We're going to talk about a test for this. I mean, the test just isn't mom discovered it, or maybe dad too. I mean, anybody, brother or sister notices little Johnny is really salty. So in order to understand the test for this, we should talk a little bit about how these CFTR channels work in sweat glands and sweat ducts, because it's a little different story. So if you have a mutated CFTR channel in a sweat gland, it causes the sweat in that duct. And the duct, of course, attaches to the skin, and sweat bubbles up through that tube, that duct, and it gets on your skin. The sweat gets on your skin, and then of course it evaporates and sucks heat out of your body. That's how it normally works. But the mutated CFTR channel causes the sweat to be way hypertonic, so it has way too much sodium and chloride compared to water. The ratio between sodium chloride is way off. In other words, it's a very salty sweat. When you see hypertonic, that means salty. Normally sweat is quite hypotonic. Even though it still tastes a little salty, it's hypotonic compared to people with mutated CFTR channels. And so how does it usually work? Normally, if the CFTR channel is functioning, it will pull chloride out of the sweat duct. So that's a little unusual, right? I just said it usually goes the other way. But in the sweat gland, it's a little different story. It sucks chloride into the cells that line these sweat ducts. And therefore, sodium, and this is normal, right? This is how it normally works. If you pull sodium out of the salt, or out of the sweat, into the lumen of the, or into the cytosol, then sodium is going to follow that in. And then water will try to follow sodium, because sodium follows chloride. Water follows sodium, but here's the rub. Water, the sweat ducts are immune to water. There's no aquaporins channels for water to come in to the cytosol. So water is trapped in the sweat duct without salt and without chloride. So therefore, normally the sweat is hypotonic, right? So the opposite happens with a mutated CFTR channel. With a mutated CFTR channel, you cannot pull chloride back in. And so chloride stays out, and the salt goes out of the cell to meet it, and you get a very salty and watery sweat. Right? Do I have a picture? Yeah, I have a picture of this. So here's here's a normal sweat duct. So here's a CFTR channel, and this is the lumen. This is sweat. So sweat's this is your skin surface up here. We'll just say this little box is a sweat duct. And normally the CFTR channels grab this processed sweat and they pull chloride ion out. And this is just a epithelial cell that lines the sweat duct. And so chloride is now inside the cytosol of the cell. And then sodium will follow through its ENaC channel. Sodium follows chloride. And then water tries to follow, and it can't. There's no aquaporins channel for it. And it can't even get between gap junctions like it can sometimes. So you have a really watery sweat, which is normal. But now if you knock out the CFTR channel, you can't reabsorb chloride. And therefore, you can't reabsorb sodium. And if you do reabsorb sodium, it goes right back out. So you get a very salty, a very hypertonic solution. See how that works? All right, so how do you diagnose? How do you make the diagnosis of cystic fibrosis? There's a simple sweat test that makes the diagnosis. And basically it's painless. They stimulate your skin with electrodes. And if you stimulate your skin with electrodes, it's going to stimulate the sweat glands to crank out some sweat. And they absorb that sweat and they analyze it to see how salty it is. And if you have too many molecules of sodium chloride in your sweat, that's not good. You have cystic fibrosis. Very high sensitivity and specificity for that. All right, now how does cystic fibrosis affect the intestine? That's kind of the star of the show today. So it's usually caught in the newborn. So anybody who's had kids know that when you're in the hospital, the nurses are like hawks. They want to know when that first bit of fecal material comes out. That's called the like egg, meconium. That's the first bowel movement that a newborn has. And it's usually dark and sticky, but it comes out. If it doesn't come out, people start to get, or the healthcare professionals get very worried, and mom and dad should get very worried because that could be a sign of cystic fibrosis. There's other things that it could be too, but here's a meconium, kind of a tarry greenish looking first stool. It's made of dead epithelial cells, mucus, amniotic fluid, bile, water. Is normally green in color, and it usually comes out within the first few days of life. And it's normally sticky, but it's not insanely sticky. Why is it sticky? Well, goblet cells are mature very quickly, and they're great at making mucin. The water comes from immature enterocytes. You'll remember from your gastrointestinal physiology. Enterocytes, when they're still in the crypt of lubricon or lubricun, they don't secrete water, or they secrete water when they're immature. And when they're mature and come out, or kind of conveyor belted out of the crypts of lubricun, they stop secreting water, but then they have all the enzymes that are so important. They do a different job. So what's the deal? Why is it so sticky normally? It's because the goblet cells mature much more quickly than the enterocytes do. And so there's not enough water around to thin it out. So normally it's sticky at first. Remember there's my little, I took all this out, but I have this on YouTube if you need physiology of the GI system. But here's a crypt of Lieberkühn here. This is a intestine. The lumen of the intestine would be here. Let's say it's the jejunum. It can be anywhere, jejunum, iliac, or ileum, duodenum. But you have these crypts, the crypts of Lieberkühn, which contain Paneth cells, are important for killing bacteria and such. But here are the immature enterocytes. And once they get up to the top here, out of the crypt, they have enzymes on them, and they serve more for digestive purposes. But when they're immature, they secrete water, which is very important. There's goblet cells scattered in here making mucin, and the water binds to the goblet cell, or binds to the mucin, and makes it kind of thins it out a little bit. So that's the deal, how that normally works. Okay. So everything I just said. So the crypts, the epithelial cells secrete chloride through CFTR channels, and the chloride gets into the lumen of the crypt of Lieberkühn, and the chloride attracts sodium, like we've talked about. Sodium comes through the tight junctions mainly, and then water follows through the tight junctions, and then the water and sodium and chloride kind of surround the mucin and dilute it out and make it more thin, so it's not so sticky. All right, and here's a little story of that. So this is inside the crypt of Lieberkühn. Here's a cell that's secreting, it's an immature enterocyte, which is able to secrete water. It has aquaporins channel, so it's cranking out water. The goblet cell, which is not shown, has already secreted a sticky glob of mucin, and the CFTR channel is cranking out chloride. Chloride will kind of hang out here, but chloride attracts sodium. Sodium will come through the tight junctions, and it will bind to the chloride. Water will follow sodium through the aquaporins channel. So you have sodium, chloride, and water kind of sticking and mingling on this medium. It's like a hangout place, this mucin. And the more water molecules you put on there, the more hydrated it is, and the less sticky it becomes. Okay, so what happens in cystic fibrosis now to that system? Well, if you have a mutated CFTR channel, you can't secrete chloride, right? If we can't secrete chloride, so if this is mutated, there's nothing to draw water, salt and water out. So you don't get salt and water, and this mucin goes and starts to build up in the intestine. And this is happening all the way down the intestine. So you have tons of mucin without water or chloride to dilute it. And therefore, that first fecal material is going to be incredibly sticky. Bicarbonate is also another player in cystic fibrosis, and we'll look at that in a minute. So that contributes to it as well. But yeah, so in cystic fibrosis, you get incredibly sticky mucin. Really, it's just mucin. And there's nothing to help the meconium to slide. That first fecal material, it's really hard for it to slide through the intestines. And it usually finally makes it through the intestines in a few days, the small intestines anyway, and it gets stuck at the ileocecal valve. Remember the junction between the small intestine and the large intestine? There's a valve that it's got to pass through, and it's so sticky it gets stuck there. And if it's stuck there and the baby's starting to drink milk now and making other fecal material, you have a roadblock, right? We have a beaver dam, and that's called small bowel obstruction. And that ain't good. So the meconium gets stuck, usually at the ileocecal valve, and that results in a small bowel obstruction. And that has a name. If we know the cause is that first fecal material or the meconium, it's called meconium ileus. Meconium ileus. Okay, guaranteed that's going to be on the test. So make a note card of that. See, if you listen to these lectures, it helps you, right? I'm basically telling you what's on the test, and that's super high yield on boards as well. Now, we've already in CVP, or no, in this class, we've talked about small bowel obstruction all well, so I'm not going to go down too far that rabbit hole. But remember this clinical signs of it. Severe abdominal pain. The baby's going to be crying, fussy. Belly's going to be bloated. There'll be vomiting. It might even be a bilious eminence, throwing up of green bile that's coming out of the duodenum. They'll percuss hypertympanic. Their stomach will be bloated. They'll have constipation, of course, or no obstipation, no bowel movement. They'll become dehydrated. We talked about the mechanism behind that before or already. And they could go into hypovolemic shock from this if it's not treated. So meconium ileus or ileum is a bad sign. Almost all infants with meconium ileus have concomitant cystic fibrosis. Not 100%, but it's a really bad sign to have this condition. 15% of patients with cystic fibrosis had this when they were small. Maybe had to have surgery to get that first fecal material out of there. Radiographs, I think I took those all out. They show signs of small bowel obstruction. Remember the stacked coin appearance and all that stuff. We're not going to go back into that in this lecture. Distended loops of bowel, lots of air in the small bowel. Oh, here, I'm going to put one picture in here. This is actually a really good picture to understand it. So here's that first fecal material. The meconium is stuck right here. Here's the ileocecal valve. The author could have made it go a little further. But that's acting as a beaver dam. And here's the other fecal material not shown, but it's stuck, right? There's a beaver dam here, so it's backing up, and the bacteria is not designed to be in your intestine forever. So it replicates and multiplies and releases gas and more gas and gas and gas, and pretty soon your intestines are stretching, and they hurt when they stretch. On X-ray, you can see all the black is intestinal gas. So this is a newborn with meconium ileus. What is the prognosis? I mean, geez, back in the day, it was always fatal until around 1950 or so, when they developed surgical techniques to unblock it. Nowadays, it's still got a fairly high mortality rate, 10%. It's unacceptably high. But I mean, you're doing surgery on a neonate, a tiny little human, so that's what it stands at. And that's for uncomplicated, assuming that peritonitis has started from this. That's worse. All right, pancreatic cystic fibrosis. Let's look at what effect it has. We know what effect it has on the GI system in general. A pancreas, we just quickly, I'm not going to go into the weeds. You've had anatomy. Remember, the pancreas is right here. Here's the descending part of the duodenum. The pancreas has endocrine and exocrine glands. It makes, of course, insulin and glucagon, which go into the bloodstream. But it also makes juices and enzymes that don't go in the bloodstream. Those are exocrine glands. And they are secreted into this pipe called the main pancreatic duct. And this pipe is dumped into the descending part of the duodenum. Right? There's an accessory, a little bit's dumped in here as well. I won't go through the parts of this though. But you can see it's just not a pipe. There's many, many smaller branches that lead to this pipe. So now we need to go even smaller. If we blow this area up here, we need to see what's making this pancreatic juice. And now here's the main pancreatic duct. That would correspond to this, maybe this piece right here. Maybe even smaller than that, but just to show you what we're doing here. And here are the pancreatic exocrine glands, and they look like little lollipops. So this is called a pancreatic acinus, or all four of them could be called pancreatic acini, is plural. And we've heard that word before. And if you look inside the lollipop, there's a lot of small little lollipops. And there's a lot of tiny little ducts. And see how the tiny little ducts connect to a bigger duct, which connects to a bigger duct and a bigger duct. And so that's the ductal system. And these ducts are lined with epithelial glands, or epithelial cells, which have CFTR channels. But the juices, all the enzymes are secreted by these cells. They're called They're called acinous cells, or acini cells for plural. Okay. And what are some of the juices that these little tiny lollipops secrete? Well, you know these juices. Pancreatic lipase, pancreatic amylase, breaks down lipids, breaks down complex carbohydrates like starches, like breads, amylase. Not to be confused with salivary amylase. Peptidase is super important. Break down all sorts of proteins here. Nucleases, cholesterol esterases break down cholesterol. Phospholipase, there's all, you name it, we can break it down. So these are super important. And all these little enzymes are secreted in inactive forms, of course, into this ductal system, and that's about all the deeper I'll go into that, because we're studying cystic fibrosis. So the star of our show here is these ducts, and these ducts are made up of epithelial cells, and they're called intercalated ducts, and therefore these cells are called intercalated duct cells. Sometimes they're called pancreatic duct cells or just duct cells. And these duct cells have the CFTR channels within them. Okay? All right, so duct cells, they don't secrete pancreatic enzymes, right? Those are from the little lollipops here, the acinar cells. But they do secrete some very important stuff, like salt, chloride, anion, via a CFTR channel. So they have CFTR channels in them. Bicarbonate ion, mucin. So there's no goblet cells here. The mucin is secreted from the same cell where the sodium and the water are secreted from. So kind of an interesting little setup here. CFTR genes in the pancreas. So CFTR channels play different roles in the pancreas. We don't know the full story yet. CFTR channels still initiate, so chloride still goes out of CFTR channels. The only place it goes into CFTR channels was that the sweat glands and sweat ducts that we talked about. But it's weird what happens to the chloride. So instead of going over and calling salt and water out of the epithelial cell, the chloride is immediately sucked back inside the ductal cell. It's like, what's the point of that? Why kick out chloride only to suck it back in? Because it gets sucked back in through an exchanger, through a bicarbonate chloride ion exchanger. And what we need here, we need a negatively charged molecule to attract the salt and water, because we used to just use chloride, but that's not going to work in this pancreatic juice because it's too acidic and it'll wreck the pancreas. We need to use bicarbonate. We need a molecule that is more basic. And so we're going to exchange the chloride immediately for bicarbonate, which can do the same job as chloride, i.e. it can attract the salt and water. And it's got another bonus because its pH is quite high. It's quite basic. And therefore it neutralizes and kind of raises the pH of natural occurring pancreatic juice. So that is the story there, everything I said. And let's take a look, and you can read about it here. But here is a CFTR channel, and it cranks out chloride. And this green thing is the mucin again. But instead of calling salt and water out, it's immediately sucked back in to the epithelial cell. And when it gets sucked back in, bicarbonate gets kicked out. So it has the same effect. So we have a negatively charged bicarbonate ion here, sucking out sodium, sucking out water. Sodium follows bicarbonate now, and water follows sodium. So now the sodium and the water, the bicarbonate can surround this mucin, this sticky, nasty mucin, and thin it out so it doesn't get stuck in the pancreatic duct. That would be bad, right, if it got stuck in the pancreatic duct. So now we know how it works. What if the CFTR channel is broken? Well, that's not good, right? If CFTR channel is not if it's broken, we can't get chloride ion out into the lumen, and therefore there's nothing to exchange bicarbonate. So not only is the CFTR channel broken, so no chloride, this one might as well be broken as well because we don't have chloride to drive that. So we don't have bicarbonate out here. What's going to happen to the pH out here? It's going to become acidic without bicarbonate. And that can cause an inflammation and can start to damage the ductal system of the pancreas. And ultimately, you can get beaver dams somewhere, and those enzymes that are secreted in inactive form can start waking up and destroy, auto-digest the pancreas. And that scenario I just talked about is pancreatitis can happen. In addition to other sequelae we're going to look at here. So yeah, that's everything I just said right there. You can read it. And then, therefore, notwithstanding the inflamed pancreas, there's nothing there to thin out the mucus or the mucin. So the mucin can get stuck in these ducts and can back up, and the proenzymes, if they hang around inside the pancreas too long, they can wake up and become full power, like trypsin can wake up, and it's a powerful proteolytic enzyme. It can eat a hole right through the pancreas. So see, we have all sorts of trouble, and that's pancreatitis, right? No bicarbonate, pH is going to be too low, and it's going to become an acidic environment. So not good. The acidity inflames the pancreatic ducts and causes pancreatitis. This is seen not all the time, but about 2% of people with cystic fibrosis have this problem. All right, but now we have the pancreas spitting out a more acid solution. So how is that going to affect things? Well, it's going to decrease the pH of the small intestine. And that's going to, again, you also have acid coming out of the stomach that it's not going to be able to neutralize. So bottom line, if you have too much acid in the small intestine, you're going to start to get ulcers. It's going to inflame the mucous surface, and inflammation can lead to an ulcer formation. Plus, the low pH messes up fat digestion. If you have a low pH, it messes up the ability to convert fat into micelles. Specifically, it precipitates bile salts when you need bile to make these micelles. And fat has to be put in micelles in order to be digested. So the bottom line is the fat goes right through you and you get a really fatty looking stool. Steatorrhea, we've talked about that before. Okay, so the bottom line, cystic fibrosis, people, they suffer pancreatic exocrine insufficiency. And the pancreatic endocrine function is fine. So they still secrete insulin and glucagon. So that's where I'll get you on the question, right? Make another note card. That question is coming because I'll test you to see if you know the difference between pancreatic endocrine versus pancreatic exocrine function. Now, in the very end stages, it can start to spill over and destroy endocrine function, but that's way late in the process. Here's the main pancreatic juices, the peptidases, trypsin, chymotrypsin, procarboxypolypeptidase, elastase. And these are the real enzymes, right? They're secreted in proenzyme form. Pancreatic lipase breaks fat into glycerol and fatty acids. This breaks down proteins into various smaller amino acids and dipeptides and tripeptides and such. Amylase breaks down polysaccharides into disaccharides. Phospholipases break down phospholipids into fatty acids and glycerol, right? This is all review for you guys, right? If you're listening to this on YouTube, you're going to be lost. I mean, this is for my students who have already had these classes. So I'm not going to have time to go through all this. Nuclease. There's a nuclease that cuts DNA and RNA up into its fragments. Cholesterol esterase. Takes a cholesterol ester, chops it into cholesterol and fatty acids. And let's not forget bicarbonate is also made from Brunner's glands. So that's important as well. What are the pancreatic insufficiency? What are the clinical findings? Well, fatty stool. So steatorrhea. if you can't break down proteins into at least or at least into amino acids and dipeptides, you can't reabsorb it, so you won't have amino acids. Without amino acids, can't make albumin, and you're going to have generalized edema, which we've talked about before. Failure to thrive. I mean, you need amino acids. You need all these proteins and carbohydrates and fats. You need all that stuff for a child to grow. They might get a normocytic anemia on top of that. And yep, steatorrhea, we talked about. Fat maldigestion, protein maldigestion are key indicators that the child has pancreatic cystic fibrosis. How do they present clinically? About the third time we've said steatorrhea means fat maldigestion. Azoturia means that there's high levels of nitrogen in the stool because the protein's not being broken down and not being absorbed. Fun facts, 87% of patients with cystic fibrosis have some evidence of exocrine pancreatic insufficiency. It's usually progressive, and exocrine, kind of a fun fact, you need about a 90% loss of pancreatic lipase secretion and trypsin secretion to actually clinically show up. So if those symptoms show up, your pancreas is really in trouble. The pancreas can get so inflamed that it atrophies and becomes fatty and full of cysts. The islets of Langerhans, which are the ones that make insulin, are usually spared until very late in the disease process. So you could get diabetes way late in the disease process. And exocrine pancreatic insufficiency, more fun facts. So we already said that class 1 and 2 and 3 mutations are the severe ones. They cause severe pancreatic insufficiency. This can independently cause lung cystic fibrosis. So you can have lung cystic fibrosis and pancreatic cystic fibrosis at the same time. You can have one and not the other. There's all different kind of mixes of this stuff. And let's see, other non-pancreas related causes have been documented to cause EPI, such as Zollinger-Ellison syndrome, diabetes, celiac disease, and Crohn's disease. So, I mean, cystic fibrosis definitely is not the only thing that causes EPI. What's the treatment for EPI? Well, you can give the patient replacement enzymes, so pancreatic enzyme replacement therapy, and that will help. But of course, if it's caused by cystic fibrosis, there is no cure for cystic fibrosis. All right, see you later.